So my name is Aaron Levo. I'm the Vice President of Communications and Public Affairs. Welcome to our town hall for Thursday, February the 11th. We have a number of presentations lined up today. Our President and CEO, Rob McIsaac, couldn't be with us today. He has a pandemic planning meeting that he's chairing. So once again, we have our EVP of Corporate Affairs, Dave McKeag, who will kick things off today with some remarks, and I'll be back at the end of our webinar to moderate a Q&A. To ask people, if you can, hold your questions until the end for the Q&A, just in the event that maybe one of the presenters addresses the topic of concern for you. So Dave, over to you to give us some opening remarks. Thanks.
Yeah, good morning, everyone. And if you're watching this on the recording, apologies for not having the link available for this morning. These come fast and furious. It doesn't even feel like it's been a week since we were talking together, but here we are. So this morning, almost a standard set of agenda topics for us to go through. Well, a lot of our attention is naturally focused on vaccines and outbreaks and maybe a little bit new, the provincial lockdown status. We'll take some important time today to follow up on the dialogue that Bruce touched on last week at the start of Black History Month. He'll be joined this morning by Sanjay for an update on the President's Advisory Council on Equity, Diversity, and Inclusion, a very, very important discussion. We'll go on and also have our normal updates on the pandemic response, the status of the virus in our community, and also about vaccines and what we can share there and what we've learned over the last week and work underway there. Many will already be aware we started administering second doses yesterday, which is wonderful. We're also working on a plan to scale up our fixed clinic site once there is a consistent and stable supply of vaccine for our community. Stay tuned for more on this front in the coming weeks. We still continue to be optimistic, and we'll hear a little bit more about some of the planning beyond just Hamilton Health Sciences fixed clinic with respect to getting vaccines across the entire community. So that's exciting. As always, just a thank you for all that you do for our patients, for each other, for staying vigilant, for helping everyone to do everything that we can to fight this fight this virus as we all wait for vaccine to have the impact we all hope for. So with that, I think I'll just now turn it over to directly to Sharon, who's going to talk to us about pandemic response planning.
Great, thank you, Dave, and good morning, everyone. My update this week sounds very much like my update last week, but a little bit more positive, as you'll see through some of my comments, or hear rather. In terms of what HHS is doing, we continue to manage all of our sites in efforts to maintain sufficient capacity for COVID and also ensure we have capacity for our routine non-COVID care. Our occupancy does, as I've reported every week, remain very high across all of our sites, including McMaster, if you look at our bed boards today. And important to realize that with that high occupancy, we still are not doing all of our pre-COVID surgical volumes. We're still only at 80%, and yet we have these very high occupancy rates. So it really does reveal the pressures that are on the system with COVID and also related to some of the challenges we face with our post-acute care and our discharges. The good news is, we have the COVID's below 50 on the slide, but actually, if you look at the board this morning, COVID's actually today below 30. Which is, when you think a few weeks ago, I was reporting that we were getting very close to 100 is very good news. And Dominic will be highlighting the patterns and the trends that we're seeing that we now see reflected in our hospital activity. Regardless, the system remains very strained, and you can see in the bottom right, the transfers. This is part of that load balancing, census balancing activity that's been happening across the province now for quite a few weeks. So you can see the numbers in terms of the patients that have come into the HNHB area. And we continue to have those daily conversations about who has capacity to assist the more central provincial hospitals. So if you go to the next slide, some good news on the next slide relates to our outbreaks. And you can see we're down now to just outbreaks at the Jaravinsky Hospital, which is wonderful because every week we've been reporting across all our sites pretty much. Just this morning, the Satellite Healthcare The last or the second unit came out of outbreak, which is great. Also out is the general in West Lincoln. And as I reported last week, we had declared a new very small outbreak at Grace Phillip that has now been resolved. So that's good news. The other community outbreak situation, we're also seeing some improvement at the height of the long-term care and retirement home outbreaks. There was almost 30, I think a high of 29, and we're down to 11. And public health is reporting that those outbreaks are becoming fewer, as we see in the numbers, but also much shorter durations and fewer impacts. So that's very positive news. So like Dave, thanks to everyone for all the fabulous work, and really hoping we're seeing a bit of that proverbial light at the end of the tunnel. Happy to answer questions later, but I'll pass it on to Aaron.
Thanks very much, Sharon, and thanks to Dave as well. So I see we do have some more participants joining us. Just a reminder for those that are joining, with apologies, the normal link didn't go out this morning as planned, but you can catch what you've missed in the recorded version. Boy, it's something. I would really encourage you to do that and make sure that you catch up on what was said already. So moving forward in our agenda, we have an update from Dr. Dominic Mertz, our Medical Director of Infection Prevention and Control, as always with us to give an update on the epidemiology of the pandemic and what's happening in the community, region, and beyond. So Dominic, over to you.
Yeah, thanks, Aaron. Next slide, please. You're all familiar with this slide. In the meantime, you see in the black circles the cases per 100,000 per week in each province and territory, as well as the RT values in those arrows. Above 1 meaning number of cases continue to increase. Below 1 means that number of cases are decreasing over time. Still Saskatchewan with the highest rates, 120 currently, but when you look at the RT of 0.89, that translates into 10% reduction every 4 to 5 days. So certainly on the right track there as well. Ontario sitting at 65 right now, also an RT significantly lower than 1, so cases continue to decrease, and today for the first time in a very long period of time, less than 1,000 cases, so back in the 3 digits. The only large province, or heavily affected province, I would say, that doesn't have a RT of less than 1 right now is BC, that's sitting just at 1. I have 2 red arrows here, Nunavut as well as Labrador and Newfoundland, which are typically regions where we see 0 or very small numbers. They both are struggling with a wavelet at this point of time, but things seem to get under control again. Next slide. So this is our provincial view, Ontario. You see the well-known post-holiday peak there. Took us 1 to 2 weeks to get back to where we've been before the holidays, and since it continues to decline, we are sitting at roughly, well, 50 to 60 per 100,000 per week at this point. So that's similar to where we were at end of October, beginning of November. Next slide. This now also translates into hospital admissions. This is again across the province of active COVID cases. We are now below where we had been at peak during wave 1, and almost half the number of patients admitted then during peak in the beginning of January post the holiday peak there. So things certainly moving to the right direction in terms of hospital capacity as well. On the next slide, you see the Hamilton situation. So again, our rate per 100,000 per population per week. Last bar, not reliable because we are still in the middle of the week, I guess. I think we had another 50 cases roughly today reported. So this translates into, again, similar to Ontario on average, somewhere in the range of 50 to 60 per 100,000 per week. And again, that's where we've been end of October, beginning of November. But I keep saying, and that's in keeping with what Sharon said, it doesn't feel the way as November felt so far. And that's mostly because we still have a sort of the consequences of a higher epi behind us, while in November we were coming from a lower to a higher epi, and our hospital experience, I would say, is always delayed by several weeks compared to what's happening out in the community. Next slide. This is the community cases per 100,000 per week. As you remember, we implemented the non-low epi policies once we were hovering around that 20 per 100,000 per week mark back in end of November. We are now this week for the first time clearly below that. As I said, the lived experience at this point isn't that we are at where we've been back in October and November. Hence, there will be no changes to the policies at this point of time, despite the number of cases continuing to decline in the community. On the next slide, you see the hospital situation. We are still locally above where we've been at peak in wave 1, which was the day that we decanted the Roslin with a total of 70 admissions across the city. But again, numbers continue to decline in terms of ICU, also post-peak. So also in Hamilton, where we had some more delay compared to Ontario, we now clearly see the decline in number of cases that require hospital care. Next slide. Which brings us back to the modeling that I've shown last week already. It hasn't been updated yet. And when adding on the next slide, the line where we are currently at, and just to make it easier, I kept it a straight line. Next slide. You see we are pretty much in that best case scenario that the science table considered plausible. So sitting at around 1,000 cases at this point of time. So clearly on the best possible trajectory when you're considering what the assumptions had been 2 weeks ago. Next slide. And I did the same here for the slide from the science table that looked at differences between schools being open, which is the blue line, and orange line, schools to remain closed. We are pretty much sitting in the middle of those two curves as predicted by the science table. So pretty close here to their predictions, and we will see over the next few weeks how things will continue to evolve. We are all aware variants of concerns are something that we are following closely. So far, still no cases in Hamilton, but I think everyone knows it's a matter of time. It may already be here, but we haven't captured it yet. But so far, we are still sitting at locally at no cases. There was a case in Niagara. We had case in Haldimand, Norfolk, and in Burlington. Okay, I close here and back to you, Aaron.
Thanks very much, Dominic. So next up on our agenda, we have Leslie Gauthier, our Vice President of Clinical Support Services and Surgery, to give us an update on the vaccination effort underway. Leslie, over to you to give us a bit of a survey of where things are at this week.
Oh, thanks, Aaron. Good morning, everyone. So high-level message is all looking very positive on the vaccine work. People will know, many people on the call will know that the fixed clinic, and that's how we're referring to the clinic that operates from 293 Wellington, resumed administering second doses to our healthcare workers this past week. So both people, individuals from HHS and St. Joe's. So they have been scheduled. Needles have been going into arms as of yesterday. And we will continue to schedule people. We're working really closely with the supply of vaccines. So once we have confirmed line of sight, appointments are being scheduled. Important message that everybody understands. At this time, the province has still not given us direction to resume administering first doses. So we're doing planning and we're ready to start that work and scheduling people in for first doses. But again, we're waiting for the province to give direction to all of the organizations that we can start more first doses. Really exciting is that the province is asking municipalities, public health departments to begin planning for very large scale vaccination clinics. My colleague Bruce Squires is on the call, the panel this morning, and if people would like some more specifics as to what that planning is looking like for Hamilton, we can share some high level messaging, but important that people know somehow people have line of sight that we think we'll have enough vaccine that these very big clinics will be starting within the weeks to come. So very promising even outside of the organization. Next slide, please. So the other really important update on vaccine is for our patients. So we have started to vaccinate HHS and St. Joe's patients with ALC long-term care designations. So that work is underway. It actually is our public health mobile teams are present in our hospitals and working with the clinical teams to make sure the identified patient populations are starting to receive first doses. Likewise, the satellite health facility will also be, patients there will also be done this week for both HHS and St. Joe's. And my last message is the same message, no matter which task force I'm representing on the webinars, and that is super good news that we have some line of sight to stable supply of vaccine, and that work is starting to resume. We don't want anyone to forget the very first line of defense against COVID is your basics in terms of wearing the appropriate PPE, making sure everyone consistently is practicing good hand hygiene and practicing physical distancing. And just that we owe it to each other if we see colleagues who might have forgotten or had a slip in their practice, the gentle reminder, we need to take care of our patients, take care of ourselves, and take care of our colleagues by reminding people of those basic principles. So thank you, and I'm going to turn it back over to Aaron.
Thanks very much, Leslie. And I see in our Q&A some questions already coming in around details. Just a reminder to everyone, we'll have a Q&A in a moment. But next up on our agenda is our Bruce Squires, our VP of Women's and Children's Health, along with his co-chair, Dr. Sanjay Sharma. So Bruce and Sanjay, over to you.
Thanks, Aaron. Good morning, everybody. So earlier this year, some of you know our CEO called upon our staff, physicians, and community members for their involvement on this newly created President's Advisory Council on Equity, Diversity, and Inclusion. And as Aaron mentioned, it's being it's being co-chaired by myself and Bruce, who's the president of the Children's Hospital. So we had a large number of people who put their name forward to be involved in this important work, and it was made up of a diverse mix of individuals who had authentic and active connections to their communities, as well as staff representing HHS and our academic partners. From this, a group of over 50 members who will serve as our advisory council in our initial proposed structure has been established. The group went through the initial engagement meetings, and they've offered their input into furthering the structure of how we'd like to tackle the work as we move forward. And so based on this input and in alignment with the work of our community partners, a preliminary drafted work plan has been started around selected broad categories. And the next steps really are to engage the council in providing their input into developing the structure and direction of work within these categories to ensure we have authentic engagement and the appropriate breadth of activity. And so the larger group will begin monthly meetings in March. And once the group has settled on directions, smaller core teams focused on the specific categories you see there will meet more frequently. And the group will also create frequent touch points directly with the CEO and the board to engage in this important work. And so once the items are finalized, we'll house them corporately to keep our staff, physicians, and community members aware of the work that's ongoing. And the group will continuously be supported by our human rights and inclusion team, as well as our communications and public affairs professionals, allowing us to build on the great work that they've established even prior to this. And so if we go to the next slide, please. So aside from the direct work of the President's Council, there have been a variety of other learning opportunities surrounding EDI that we'd like to highlight. As part of our leadership sessions, our staff has had the opportunity to expand their EDI and anti-racism knowledge through workshops by Dr. Desani and Dr. Kasha Johnson. Additionally, we've had positive participation on our EDI-focused courses offered by our Human Rights and Inclusion team in the Center for People Development. And that team has also developed EDI-related training that will be offered at the department level, and further information on that will be shared when it's ready. And finally, on top of this, we're continuing to celebrate Black History Month and encourage everyone at HHS to take the opportunity this month to celebrate Black history and culture and learn more about the stories and contributions of Black Canadians to the growth and development of our country. And on the Human Rights and Inclusion events page on the Hub, there's information on ways to celebrate despite the pandemic. And everyone's invited, and we really encourage everyone to attend and participate. So with that, I'll turn it over to Bruce now.
Thanks very much, Dr. Sharma. It's certainly a pleasure to work on this advisory council with you. And good morning, folks. And I would just like to highlight as well that, as we all know, Hamilton sits within a wider community, and so equity, diversity, and inclusion work continues to progress across our broader community. And the work plan for the advisory council will take advantage of and look to enhance opportunities to share and to work together with our community partners and peers. What you see on this slide are some examples of recent work where the organization has become part of and has supported and has capitalized on those outside activities. That includes the Child and Youth Services System Committee and across Hamilton and their statement with respect to anti-Black racism. The Hamilton Health Team, that broader, really multi-partner group looking at transforming our whole healthcare system, has recently issued its call for the HHT Equity, Diversity, Inclusion Steering Committee. And so we'll actively participate in that. And HHS remains a longstanding partner of the what's referred to as the Anchor leadership. And they have formed as well an EDI task force that's focused on advancing similar principles in EDI. So we're going to continue to connect to and monitor the developments in that area, in that space, and look to really collaborate and enhance the efforts of our community partners, thereby supporting their work and the community's work on EDI and our own. So thanks very much for this opportunity to update our team. I'll turn it back to you, Aaron.
Thanks very much. Thanks, Bruce, Dr. Sharma, for that update. We now have time for a Q&A session with our participants. So remember, you can ask questions in the Q&A slot down below. You can also raise your hand in the participants forum, and we'll call on you to ask your question live, should you wish. If you do, anyways, you can always raise questions after the fact via email and send those to the HHSC. Bit of a rocky webinar today, guys, to the news@hhsc.ca inbox. All right, I'm going to go right to the first question here. Dr. Mertz, I think this might be something that you can shed some light on. The questions around whether or not the current reduction in prevalence might be a result of the vaccine or people practicing the prevention measures of, probably physical distancing, masking, et cetera. Maybe to phrase that a little way, do you think it's reasonable to expect any impact as of yet from the vaccinations that have occurred in our city region?
I think the answer is definitely no. I don't expect that this has anything to do with the vaccine at this point of time, keeping in mind that the population that's been vaccinated among our healthcare workers are not necessarily working in those settings where we saw most of our outbreaks, right? So definitely no in terms of that. Will it have a long-term impact? For sure, in particular once we have healthcare workers at large vaccinated, and the more data we get on transmission, the more reassuring it seems to me. It seems to be that through the vaccine we will actually see less transmission on top of people who got the vaccine not getting any symptoms from the infection. So it will help us to build some level of herd immunity within our hospital setting to prevent transmission to other healthcare workers who are not vaccinated or who choose not to get vaccinated, but most importantly to our patients as well, who may not have had a choice yet to get vaccinated or not, certainly not at this point of time. The single most important factor that reduces outbreaks is the simple fact that we have much less COVID pressure and COVID cases coming in from the community. That's the single most important factor here. I hope that, and I think with all the work on the way to improve the use of PPE, it's probably a contributing factor, but I think the single most important one is there's simply less COVID coming in through our staff and through our patients that goes first undetected and resulted in outbreaks.
Thanks. Well, I have you on screen. There is another question. Perhaps you can comment on how well we know about the effectiveness of any of the vaccines with respect to the variants of concern. The question here is specifically the South African variant, but is there any emerging science now around the effectiveness on these variants of concern?
So there was the data on the AstraZeneca vaccine that was sort of disappointing, depending on what your expectations are in terms of how well it worked for the South African variant. Very small studies though, and still no severe cases. So it looks like more breakthrough in terms of mild infection to moderate infections than you would have expected with other variants, but still quite reassuring within that small sample that that it actually protects from severe illness and death potentially. However, it looks like the mRNA vaccines may potentially be better in terms of the South African variant. We have less data on the Brazil variant. But overall, it seems like, yes, it's not a yes or no whether it works or not, but it seems like it's working less efficiently for those two variants of concerns. For the UK variant, we have quite reassuring data at this point that the vaccines work as well as for the current variants that we have in Canada. So we don't expect a downside of the UK variant from that perspective. The concern really there is that it seems to be more easily transmittable.
Thank you very much. Another question here, maybe Leslie, this one, maybe you can comment, like really about the prioritization of mass vaccination. I think it's at the heart of the question. The question's about Manitoba, people over 70 being prioritized. At this time in Ontario, correct me if I'm wrong, I don't think we have a prioritization framework for broader vaccinations. Is there any thought within anything we're doing now about age as a prioritization factor?
So really good question, and thank you. So the framework that HHS and St. Joe's put to paper was built on the provincial prioritization sequencing framework that was published a few weeks ago. We do believe that the province is looking at that framework and may give us different direction, although we have no specifics, no line of sight to what that might look like. I think it's really important that when you read the sequencing frameworks, they do speak to prioritizing people over 70, but that's really based on if you only have 10 doses to give and you have 20 people waiting, how might you choose to approach that problem? And so that's around vaccine scarcity. And we're really optimistic that within a few weeks, we don't have a number, but we will have line of sight to lots of vaccines. So we won't need to approach it from a scarcity perspective. It will be big mass clinics and again, people will sign up. So the short answer is there is no direction to allocate based on age at this time. It's referenced, but it's referenced in the concept of scarcity. So we're not quite there yet. Other provinces have taken different direction. I don't know, Bruce or Dave, if you wanted to add to those comments.
I would only say, thanks, Les. I would only say that, yeah, we do think there is likelihood that when we move to the end of the phase 1 of the provincial plan and into phase 2, that which is much more broadly based in reaching the population, that there's a likelihood that that will have an age basis to the sequencing.
Probably, Aaron, my other comment, and we didn't celebrate it, and I think we really should celebrate our public health colleagues. Hamilton has done an exceptional job of getting the residents in long-term care and high-risk retirement home vaccinated. So they are our most at risk and our most elderly. So we have approached from a society perspective, the highest risk groups by age. We just haven't gotten any direction as you go down from those residents. But it's a real celebration for the work that has been done to vaccinate those clients.
Yeah, thanks, Lessa. I was going to comment something similar, that it's very much been a community or you know, a grouping or a category of folks that have been the priority. So residents of long-term care is an example, but you captured it. And yes, we're very, very happy that our highest risk congregate settings have been vaccinated in Hamilton. That's kind of an enviable position in many ways relative to some other communities that we can celebrate.
There's also, thank you, all three of you, for answering that question so comprehensively. There's also a question here about, I know, Leslie, we've touched on this in the past, but maybe you could give us a quick summary of, like, as it relates to how many first doses we have left in tier 1 to do. It's very exciting to think that pretty soon we're going to get back at it. What does that effort look like? Like, how many people in tier 1, tier 2? What is your thinking right now?
Yeah, so I saw the question in the chat box, so I took a second to look up on our dashboard. So for HHS, we have around 2,600 people waiting for second doses as of this morning. Again, the clinic is open and running for the next few days, and our real goal is to get through as many of those people as possible. Again, we're being careful in what we're booking until we have line of sight that the next dose of deliveries here. All the signals are telling us the doses are arriving, but when we actually see the vaccine on the receiving dock, we'll feel better to share that information with people. But it looks like about 2,600 people left to get second doses, the majority of whom have been scheduled into the clinic. Sequence group 2, off the top of my head, is around 1,800 more people to start vaccinating. And then about 50% of our team is residing in sequence 3 and 4. So.
Gotcha. Thank you. And I think, Bruce, you had mentioned that you had an answer for the question about the appointments starting for those who were initially scheduled for the first week of February. So this would be second shot appointments.
Yeah, and Les has alluded that, but to be really specific. So doses are happening from the 10th to the 14th. The next appointments, you should receive your notice sometime next week for the date for those remaining second dose appointments. And so in the course of that next round, we'll have gotten through all of the second doses. That'll be scheduled next week once we confirm our next delivery.
Good stuff.
Yeah, I'm gonna just to because I answered one of the questions in text, and you might not see it, Aaron, but specifically in terms of the time frame, we do expect, based on all available information, that those that already received a first dose will receive their second dose within the 35 to 42 days. So within the 42 days at the end point. So we're optimistic about that at this point.
Thanks a lot. There's a question here, kind of intermingles with some information I heard yesterday about news that people infected with COVID after receiving the vaccine, that I guess it then might create a super strain. And could you comment on the validity of this? Maybe, Dominic, you could offer some perspective. I had also heard yesterday, quite to the contrary, that the vaccine was having an effectiveness rate in terms of reducing someone's viral load to the point where they likely were not even spreading the vaccine, or much less likely to spread it at all. Can you talk a little bit about the science on this and what we know after vaccination? What is happening in somebody's body with respect to this virus?
Yeah, so I guess the question is whether having a semi-immunity through only one shot of the vaccine may increase the risk of variants or super mutations or whatever. Great hypothesis, not evidence-based to the best of my knowledge. I haven't seen anything that would suggest that's happening. And as Aaron said, if anything, it looks like just the one dose already protects you quite significantly after 2-3 weeks. And I'm not aware of any evidence whatsoever that it puts anyone at risk when you're walking around with just the one shot for several weeks. So I know the media picked that up, but it's a hypothesis and nothing above and beyond that.
And as we hear about things like super mutations and variants of concern, like what point would you consider a third wave? Like, is that possible nomenclature we would ever envisage? What would need to be true for that to be discussed?
Well, we don't have a clear definition of what a wave is, and people probably remember fall when people said, no, it's not a wave yet, it's not a wave yet, now it's a wave. It's nomenclature in the end of the day. Bottom line is, once you're going down, and as you know, and I've shown you, we are going down, and then it goes significantly up again. At some point, you would consider it a new wave, or some people sometimes use the term wavelet if it's just a small hump. When you're looking at the epi curve in BC, it more looks like ongoing wavelets rather than a clear wave, because they've never went into such extreme lockdown measures as we did. May it happen? Yes, it may happen. When does it happen? Everyone has a different crystal ball, and we will see who will eventually be right. I think my gut feeling is if it happens, it will probably be towards the end of March, but it heavily depends on what those variants of concerns will be doing, how the measures out in the public will look like, how much pandemic fatigue there will be, and how well people will adhere to all those tiring policies that we have with reduced social interactions and so on. So there's not many factors playing into it that nobody can clearly say it happens then and then. I know in the media there's people saying, yeah, definitely it happens, definitely by end of March. We don't really know that. And the other piece, I think, it's a seasonal virus after all, and we don't know yet to what extent that may help us already in March or April. It certainly, as it's shown last year, with summer coming, the better weather will help us because everyone is moving outside and it has less benefit in terms of transmission. So many factors playing into it. I wouldn't say we can predict it at this point of time, what's exactly going to happen.
And thanks very much for that answer. There's another question here that maybe you can comment on around surveillance testing in our sites. Is that an effective way to curb outbreaks? It's referenced here that perhaps that's what's happening in schools and elsewhere. What would we ever consider that kind of broad testing approach in the hospital for patients or staff?
Never say never. On the other hand, I mean, what we've learned through all those outbreaks is that the testing wouldn't have prevented the vast majority of them, or whenever we actually had a good indication how it started, many of those patients that may have triggered the outbreaks actually had at least one or sometimes two negative tests, but they were incubating at that time period. So eventually they developed the infection. We weren't aware until they developed the symptoms, and we have had the spread on a given unit. So, and when you're looking at long-term care, it's not really a success story what happened with the testing, right? So it's certainly not clear-cut. And the whole school testing, as supportive as I am, that it may be a good undertaking and should be done to understand what's happening. Nobody argues at this point of time that this will prevent someone from walking into a school potentially infectious, because frankly, you would need to have to test everyone every single day to prevent that from happening. At best, you can capture transmission earlier, and also keep in mind that all the rapid tests that will eventually make broader testing on a regular basis possible, they have a lower sensitivity, so you're missing more cases, but the fact that you can test more frequently makes up for that. So all of this being said, we plan to use PanBio, which is the rapid antigen test, as a first trial in our satellite health facility, and hope to be able to roll that out within the next week or two. That will give us some experience with what may be the potential benefit of doing this, and then consider whether there's other settings where we might be rolling that out as well. At the same time, long-term care is doing the same now. We will learn from them whether there's added value. All of this will become less and less important once people are vaccinated.
Okay, so one last question, then I'll let you out of the hot seat, I promise. Thank you for your patience. It's around, I know we've addressed this before, but can you quickly address the issue of double masking? A couple of questions came in today. You know, where do we stand in Canada and Ontario and Hamilton and HHS on the subject of double masking? It's a very popular discussion topic right now.
Yeah, and it's been fueled again by a CDC experimental study that came out yesterday. And I just find it surprising how many great studies are being done out there and the media don't care, and then some experimental study comes out and all the media are jumping at it. But all of this being said, it's certainly on our radar. As I believe I said last week, there's a clear no for any double masking when you put a medical mask on top of an N95. That will negatively affect the function of your N95. Don't do it. We don't want to see that. Ministry of Labor doesn't want to see that either, and it would get flagged. The double masking that's now coming out of the report that was published in the CDC paper is looking at putting a cloth mask on top of a medical mask. We discussed this extensively this morning, and the study is flawed for multiple reasons, and I don't think we have the time to get into that. We decided to put a one-pager together that we will probably share either tonight or tomorrow night, coming out with the daily updates, which provides you some details about our interpretation of the study, what the study limitations are, what the takeaways are. Our takeaway in short is we don't want staff to double mask at this point of time. N95, definitely no. You put yourself at risk if you double mask. The nodding strategy may be of potential benefit. So if you have a small face, and that's been one of the issues with that CDC study. So they used a medical mask that was a very bad fit, right? If your medical mask, because you have a small face, doesn't fit well, the nodding, and we will add links to that where you can watch how people do that, may actually be added value, may improve the fit of your medical mask, and we are happy to support you in doing that. But putting a cloth mask on top of a medical mask comes with many other potential risks, and we don't want that to happen. All of this being said, there's also the provincial group that will come together again next week. We just scheduled an urgent meeting for next week to discuss this, and there will be guidance, official provincial guidance coming out on double masking. But in the interim, it's a no to double masking at HHS.
Gotcha. Thanks for that answer. I know it's not an easy topic. See one last question in there around scientific discussion about the vaccine. I just want to point out for the person asking that question and others, we did circulate, I believe yesterday in the dispatch, an OHA video. The Ontario Hospital Association has produced a discussion video about the vaccine, the science behind it, and how to navigate decisions related to it. So you might want to check that out. At this point, I'm going to move us to our celebrations. Dave, I think you're going to give me a hand with this again this week. I know Leslie had already mentioned one earlier on. I think you were nodding your head too about celebrating the great partnership work that's happened around the vaccine, and in fact, a milestone locally around LTC residents getting their vaccinations. So that's a great place to start.
And I would just add to that, I mean, and it was covered in the content today, but a bit of a celebration that we're moving into being able to take care of ALC patients and those that are in our alternate or satellite healthcare facility, that we are able to move into those areas with some Moderna vaccine, which is wonderful. So feeling very good about that at the moment. So a lot of work goes into that and behind the scenes, and mobile vaccination teams and coordination and following patients. So a big kudos to Les and Bruce and the teams under them that are doing all of that work. So thank you for that.
I see Leslie Gillies, you have your hand up. Did you want to go ahead with a celebration?
Thank you, Aaron. I just wanted to give a big shout out to the Satellite Health Facility, West Lincoln and Grace Villa teams, as Sharon has indicated. Obviously, all 3 sites have declared their outbreaks to be over, so great work and congratulations. As well today, all of our clinical staff have returned to HHS from Grace Villa. Sincere appreciation for the exemplary care and support that's been provided to this most vulnerable population. Thank you very much.
Great stuff. I saw a note there from Kelly Campbell in the chat forum too. Kelly, you've got something that you wanted to celebrate or shout out.
Yeah, thanks very much, Aaron. I just wanted to shout out to the facilities management team who have worked over the last few months to pull together all the shelters for our screening entrances. It's taken some time and a lot of planning and a lot of coordination, but those are now all coming into place and really helping with our patients and visitors as they have to wait for their screening.
Great stuff. It's just a reminder to everybody that's still a part of our town hall today. You can type something in the chat forum. You can also raise your hand in the attendees section, and we'll call on you to give your shout out live.
Aaron, maybe given we had a little bit of a bumpy town hall today, maybe it's almost appropriate in ways. I want to thank you and your team for all the work you do to put these together, as well as coordinating. It's hard to describe the phenomenal amount of information that needs to flow to answer all the stakeholders as an organization like ours, and your team does a great job. So thank you for that.
Thanks, Dave. That's well appreciated on a rocky start day, but still we got there. Okay, I'm not seeing a lot else flow in. You can always certainly send those to us as well through the HHS news at hhsc.ca inbox, and we'll make sure to try and get those included moving forward, because it's an absolutely essential part of weathering the pandemic, expressing gratitude and celebrating the things that are going on around us. So I'd like to thank everybody that was a participant today. Maybe Dave, final words from you, and we'll close her out.
Oh, thanks, Aaron. No, thanks everybody for jumping on despite our challenges, and please have a good and very safe day. Take care, everyone.